Assalamu alaikum, everyone. Bismillahir Rahmanir Rahim. We are very pleased to start this educational series where we want to collaborate and work together to help educate students, residents, colleague physicians here in the USA as well as in Pakistan. And our inaugural session will be delivered by Dr. Muhammad Umair Mushtaq. And Dr. Mushtaq is a graduate of Allama Iqbal Medical College, currently serving as an associate professor of medicine and director of the Global Health Program at the University of Kansas. So I invite him to talk about haploidentical stem cell transplantation. Thank you.
Thank you, Dr. Anwar. Thank you so much. So I'll share my screen. Are you able to see my slides?
Yes, we can see it.
Okay. So thank you everyone for joining today. We will be talking about haploidentical hematopoietic cell transplantation, and very grateful to the UPNA Merit team for arranging this series. I think that'll be incredibly helpful, and it will hopefully improve the lives of patients with cancers in Pakistan and beyond. So I have investigator-initiated trial funded by Iovance that's not relevant to this work, no other disclosures. So when we talk about bone marrow transplantation or hematopoietic cell transplantation, it started first procedure in 1950s. The first program essentially developed in 1970s. Dr. Don Thomas got Nobel Prize in 1990 for his work in bone marrow transplantation. And when it started as that you can use a matched sibling donor. So a human leukocyte antigen HLA identical matched sibling donor was used as a graft source. Quickly, they learned that there are two main problems. One is the relapse of primary disease, especially malignant hematologic disease. And second, what was called a foreign bone marrow disease or graft versus host disease. And with the refinements in the way we type HLA and improvements in the drugs we use for preventing graft versus host disease, now we are able to do transplantation using unrelated matched donors, mismatched family donors or haploidentical donors, and mismatched unrelated donors as well. With the HLA typing, it used to be A, B, and C HLA loci. So it was a 6 out of 6 match. Then we had DR beta 1, and it's 8 out of 8 match. Still 8 out of 8 is considered a fully matched donor. We now know that there are other loci such as DPB1, DQB1 that are also important, and other HLA mismatches and the directions of mismatches are also important. So it becomes rather complex to choose a donor based off of the HLA typing. However, the GVHT prophylaxis drugs have improved a lot, and that has bridged the HLA disparity. So if you don't have a fully matched sibling donor, the chances of that are around 25%. Then there is a registry that you can find a matched unrelated donor. And if you're an Asian, your chances of finding a donor are 47%, Caucasian up to 79%. And the reason being the most people on the registry are from Europe. There is also cost involved about getting a donor from the registry. That's also another constraint for the developing countries. So alternate stem cell sources when you don't have a matched sibling donor, haploidentical donors, umbilical cord blood, and the mismatched unrelated donor. And haploidentical donors are relatively easy to access. They are family donors. There is not much cost involved. People will donate free for that. Umbilical cord blood, you will need to pay for that. Mismatched or matched unrelated donor, also you'll need to pay to get the graft from the registry. So we are going to focus on the haploidentical transplant part. That's very important in context of a developing country. So access to allogenic transplant in the United States. And this graph, I'm not going to go into details of that. It is from 2006 to 2016, little older, but in those 10 years, it looks at the growth of allogenic transplantation from 20,000 procedures to around 40,000 procedures. And as you can see, the most of the growth has been in haploidentical transplants, so about 1,500 to 8,000, and unrelated donor transplants from 9,000 to 17,000. The number of related matched sibling donors, identical related donor, has been pretty stable. So most of the growth is driven by more use of haploidentical donors. This is a US data, but this also, if you look at European data or worldwide global data, that essentially mirrors that. So in the past 10 years, 2012 to 2022, the blue line here, the light blue line, represent haplotransplants, and this purple line represents unrelated donor transplants. So there have been growth in both unrelated donor and haploidentical use, more so in haploidentical use. Same thing if you look in pediatric population, especially for pediatric cancers such as acute lymphoblastic leukemia, acute myeloid leukemia, MDS, and lymphomas, there has been growth of haplotransplantation. And these two lines show the transplants being performed for AML and ALL. Not much growth in lymphoma and MDS, one that these are relatively rare diseases in kids. And there are other better options compared to allogenic transplantation in lymphoma. Survival curves have steadily improved over time. This looks at 5-year intervals from 2000 to 2005 to most recently up to 2021. And the survival has improved from about 45% to close to 65%. And the bulk of it, the main issue why the survival is low is relapse in malignant disease. As you can see in non-malignant disease, this is survival curve for aplastic anemia. The survival is 80 to 90%. So talking about the HLA inheritance, so your parents and your children are always going to be your half match because you will inherit a haplotype. So in this picture, the parents are listed. So the mother is gray and teal color, and the father in purple and green. And as you can see from the siblings, there is one who's desperate, but others are haploidentical. This is a patient haplotype. So you will have half of the, it's on the chromosome 6, so that inheritance, half of it is from father and half of it is from mother. So chances of finding haplodonors within the family are there. This again looks at the same concept in more detail. So this is a patient depicted in red and blue, and the donor is in yellow and blue. So you just need to match the half. And then this looks at more details. The class 1s are HLA A, B, and C, and class 2 are DR, DQ, and DP. And the degree of HLA mismatches in haplotransplantation is not as important. There is some importance into where the mismatch is, and that determines some of the graft versus host disease and relapse issues, especially if you're doing transplantation for malignant disease. We will make these slides available, and I'm available for any questions later on as well. So sources of haploidentical transplantation, your parents, especially in the cases of kids, all the siblings and children are preferred. And then the first and second degree relatives, if you look into the extended family, you can find several donors that could be used as a haploidentical donor. In terms of typing, in the Western world, you will do high resolution typing, and then you will start with the first degree relatives. If you do not have access to high resolution typing, then you can also use family trees and decide based off the haplotype inheritance, decide based off of that And that way will be one way to go around it. Since the studies did not show much evidence about the degree of mismatching and how much it impacts, we'll talk about some factors that are important. But any of the family donors who's have half match essentially can be used. So evolution of haplotransplantation started from the first reports were in late 1980s, 1990s further developed, and then in 2002 we have the first report with post-transplant cytoxin-based regimen, and mostly developed at Johns Hopkins in the United States. And there are some centers in Europe and China that developed an alternate protocol other than post-transplant cytoxin. So mechanisms for crossing HLA barriers, since when you were using a fully matched donor as a graft source, the risk of graft versus host disease and rejection was lower, but here you have a half-matched donor. And how do you go about bridging that at HLA disparity? And there are two main regimens that have been developed. One is T cell depletion. So the donor get growth factor and you'll collect a graft that is growth factor primed. And then that graft is CD34 selected. So you just select out the stem cells, but you remove all the T cells in it. And T cells has the potential to cause graft versus host disease, but are also important in engraftment. There are other ways to select out the stem cells. You can also do T cell receptor, alpha beta T cell receptor, and CD19 negative selection. So it'll leave you with stem cells and some NK and gamma delta cells that may be important for immune reconstitution. And you have that T cell depleted graft. And in terms of conditioning, ATG conditioning is given. ATG is anti-thymocyte globulin, so it's essentially going to kill all lymphocytes. And then you give this CD34 selected graft, and after that, you use an older cyclosporin mycophenolate methotrexate-based GVHD prophylaxis. That's one way to do it, and that's been mostly done in Europe and China. The other way to do it is give a standard conditioning protocol and give a T cell replete, unmodified graft, could be bone marrow graft or peripheral blood graft, and then use post-transplant cyclophosphamide. So at day 3 and 4 after transplantation, you give them a cyclophosphamide, and that kills the alloreactive T cells. And both approaches have their pros and cons. With the T cell depletion approach, it could be favored in non-malignant disease, but the degree of immune depletion and the immune reconstitution is longer. So infectious complications are going to be there. And especially in context of a developing country, that becomes a bigger cause for mortality in this patient. So PTCy may be a safer regimen. That's been the practice in the US, and we are going to focus mostly around that. So this is that Beijing protocol, commonly known as, this is the ATG-based protocol. So in this, this is the backbone of that regimen that they use. So ARA-C is a chemotherapy drug, busulfan and cyclophosphamide, and ARA-C-based conditioning is done. And with that, you're giving anti-thymocyte globulin that does complete lymphodepletion essentially. And the donor collection is GCSF primed. And the hypothesis is there is some changes in the T cell phenotype. So GCSF prime graft is better. Not so much believed in the US practice. You give them a T cell depleted graft, and then you give them cyclosporin, mycophenolate, and methotrexate. And outcomes are comparable in modern studies that are coming from China. But again, the infectious complications, poor immune reconstitution, relapse rates are high. And depending on which studies you look at, GVHD rates are also higher in 30 to 50% range. And this is the original regimen that was developed at Johns Hopkins using post-transplant cytoxin. So a very reduced intensity conditioning or a non-myeloablative conditioning regimen, a lower dose of fludarabine, cyclophosphamide, single fraction of total body radiation at 2 grays. And then they gave a bone marrow graft infusion. And you follow it with day 3 and 4 cyclophosphamide at 50 milligram per kilo per day. And then you give MMF for 1 month, day 5 to 35, and then tacrolimus for varying durations. Some will stop at day 60, day 90, day 180. In the other protocol, the cyclosporin is usually given up to 9 months to a year. Here it is usually 3 to 6 months, and at that time point, you'll stop immune suppression. I am not going to go into details in the interest of time for all these studies, but I'm just going to focus on the post-transplant cytoxin-based studies that have been recently done. And the modern studies show survival in 80% range. And GVHD rates are very low in 20% range. Relapse remains a big challenge. The rates are lower in recent studies. In AML, MDS population, if you look at 2000s, 10 years ago, the relapse rates are around 40 to 50%. It's probably around 30% now. I think we are getting better at treating the underlying diseases, and patients who are getting these transplants are in better remission. And the top part of this chart will show the ATG-based regimens. And the survival have been in like 30, 40%. There are few studies that show survivals upward of 90, 80%, especially in non-malignant disease. But they have not been reproducible. And in the United States, the standard of care has been to use post-transplant cytoxin. And I'll talk a little bit more about that because it's important to convince people to adapt to PTSI. Centers that are using ATG-based conditioning will stick to that, and those are usually Chinese centers, and there are few European centers, but everyone else is using PTSI now. So how does post-transplant cyclophosphamide work? So when we give a graft with the bone marrow graft, there are T cells in it. And T cells are important for engraftment, immune reconstitution, anti-cancer effect, anti-infective activity. So when those T cells are given, they are activated via the co-stimulatory mechanisms, HLA. So you'll find this HLA, there is mismatch. And because of that mismatch, you will have these T cells that get reactivated. So by day 3, there are there are all these T cells that are now alloreactive. And when you give cyclophosphamide at day 3 and 4, it will kill all of those proliferating alloreactive cells. And alloreactivity is directed against HLA where the mismatch is. And then there are these memory T cells and non-alloreactive T cells that are anti-CMV, anti-EBV, anti-HSV, and they are not proliferating. So they are preserved, they are spared. And stem cells are also spared from this process. It's a low dose, and they are not proliferating at that time. So that's a simpler way to understand how this works. There are other mechanisms such as induction of regulatory T cells, and that induce immune tolerance eventually. This is a pictorial looking at a study that compared graft versus host disease rates in matched sibling donor, matched unrelated donor, and haplotransplants. Only the haplotransplant recipients received PTSI. The matched sibling donor and mud transplants received the standard prophylaxis with tacrolimus and methotrexate. And as you can see, the acute graft versus host disease, chronic graft versus host disease, and severe acute and chronic graft versus host disease was all lower in haplo, despite haplo being a mismatched donor. And this is believed to be because of post-transplant cytoxin. This is a study, a little older now, was published in 2021 in Blood, looking at what happens, who is the preferred donor source when you're using PTSI. So matched unrelated donor versus haploidentical transplant. using PTCy-based approach. And here they show that if you use myeloablative conditioning, there is no difference in the two graft sources. If you use reduced intensity conditioning, then matched unrelated donors are slightly better. Relapse has been a big concern with non-myeloablative conditioning haplotransplantation. Many of the patients in this cohort received flu-site TBI-based conditioning. That's a very gentle regimen, and some of these findings may be attributable to the conditioning used and the heterogeneity of these patients. This is a registry analysis. These graphs are from our own internal data set at University of Kansas. We looked at, within the past 5 years, matched unrelated donors versus haploidentical transplants. And in this study, all haploidentical transplants received PTCy-based prophylaxis. Matched unrelated donors, very few of them received post-transplant Cytoxan, and majority of them, about 90% of them, received tacrolimus and methotrexate. And as you can see here, the outcomes were exactly the same. Now, if you use PTCy-based prophylaxis also for matched unrelated donor, will that be slightly better? It's yet to see. I don't think all outcomes would be better. There may be some outcomes that could be better, but overall survival is looking essentially similar. This is a blood and marrow transplant clinical trial networks 1101 study that looked at double umbilical cord blood versus a haploidentical transplantation. And the haploidentical bone marrow transplantation was better than double cord blood transplant. So as you can see, the orange line here represent haplotransplant, the purple lines represent cord blood transplant, and non-relapse mortality is better, progression-free survival, overall survival, all of that is better. Relapse is same because that's a function of underlying disease. And these studies, this supports the use of haplo as a preferred approach. There are ways to update cord bloods. There are ways to enrich it in more stem cells. But again, it's also costly. So haplotransplantation, the donors are readily available, and it's also cost effective. These are interesting results from a phase 2 trial that looks at mismatched unrelated donor bone marrow transplantation using post-transplant Cytoxan. And as you can see, the overall survival here is close to 80% at 1 year. Relapse rate, acute graft versus host disease, chronic graft versus host disease, all of that is very comparable to matched unrelated donor or haploidentical transplant outcomes. There is no impact on overall survival in terms of the conditioning intensity. Actually, reduced intensity conditioning donors doing a little bit better. There is no impact of the HLA match status, like 7 out of 8 match. That is currently considered a better donor compared to if you have more than one allele mismatch, but they did not see any difference. And this is because of post-transplant cyclophosphamide. So there is this hypothesis now that if you use universally post-transplant cyclophosphamide-based GVHD prophylaxis, HLA may not be as important as it is thought it is. And we will have more data coming up. There recently was a randomized trial in the reduced intensity conditioning transplantation using post-transplant cyclophosphamide versus CD34 selection versus tacrolimus methotrexate, and post-transplant cyclophosphamide was considered better. And that has led to kind of universal adoption of post-transplant cyclophosphamide in the United States for all donor types. This is an abstract that we presented at this ASH. This was a recent data from a CABMTR data set. 550 haplotransplants and 315 matched sibling donor transplants. And we compared the outcomes among the two groups, and non-relapse mortality was slightly lower with matched sibling donors, but all other outcomes were essentially the same. Again, pointing to the same hypothesis that with post-transplant cyclophosphamide, each degree of HLA mismatch may not be as important. There were several factors: recipient donor age, comorbidities, performance status, CMV serostatus, intensity of conditioning regimen, and the graft source that were associated with outcomes. Yeah, and these are important factors to consider and should be individualized for every patient. Now, looking at non-malignant disease in terms of severe aplastic anemia, now we suggest haploidentical transplantation upfront. There is a single center data from Johns Hopkins looking at upfront transplantation. The overall survival is 94%. GVHD rates are around 10%. Very manageable. The regimen uses ATG. It's half the dose compared to what is used in other lymphodepletion protocols. Fludarabine, cyclophosphamide. TBI is 2 fractions, so instead of 2 grays, it's 4 grays. And then there is post-transplant cyclophosphamide. And with that, you give a 1 month of mycophenolate, and tacrolimus is given for a year. And now we have this trial open as BMT-CTN trial, cure aplastic anemia. And we'll see the results of that. But the most recent guidelines from American Society of Transplantation and Cellular Therapy that we're very proud of Dr. Raheel Iftikhar. He's been the first author and he led that. And the recommendation now is to consider upfront transplantation. If you don't have a matched sibling donor, use a haplo or an unrelated donor. And outcomes are much better, because if you delay it to the relapse refractory settings, patients are sicker, they get infections by the time they get to transplant. And then the overall survival curves looks like more like 60% compared to over 90% here. This is a recent meta-analysis published in Transplantation and Cellular Therapy about pediatric transfusion-dependent thalassemia and outcomes with haploidentical transplantation. They included patients who received PTCy-based prophylaxis and also the Beijing protocol with ATG-based and CD34 selected graft-based regimen. And overall survival is over 90%. So 92% is reported. A thalassemia-free or disease-free survival is 84%. Graft failure rates are 8%. They're slightly higher if you use ATG-based regimens. Transplant-related mortality is very manageable at 7%. GVHD rates are in around 20% range, but infectious complications remain a big challenge. CMV reactivation up to 36%. And other fungal infections, sepsis up to 10%. And in my opinion, if you use ATG-based conditioning, the infectious complications are going to be higher just because the degree of immune dysfunction and longer it takes for full immune reconstitution. We now have enough data to suggest that PTCy-based prophylaxis is doable, is relatively safer. And I think there is need to develop on that in the developing country context also and report on it. So just summarizing these 3 regimens that I have discussed. So PTCy-based regimen that used flu-cy TBI-based conditioning, then cytoxins on day 3 and 4, 1 month of CellCept or mycophenolate, and about 3 to 6 months of a calcineurin inhibitor. That's usually tacrolimus. Versus Beijing protocol that uses ATG-based lymphodepletion, a CD34 selected graft, and then cyclosporin for up to 9 months to a year, CellCept. They also add methotrexate to intensify that GVHD prophylaxis. And this is pretty intense immune depletion. And then there is aplastic anemia protocol that just amplifies the dose of TBI in that flu-cy TBI regimen and gives half the dose of ATG. to get the graft in, because when the initial studies, they did the low dose of TBI, or if you don't use ATG, then your rejection chances are going to be higher, because these are non-malignant disease patients. They have not seen chemotherapy before. They have intact immune system. So higher immune depletion is needed. Our preference in the United States has been post-transplant cyclophosphamide. So I am going to stick with that for future discussion. So in terms of the donor selection, so I think the most important factor is that there should not be an HLA antibody. So because of the transfusions that recipients receive, they may develop antibodies, and the antibodies are often directed at the HLA loci that are mismatched. So donor-specific HLA antibodies at cytotoxic cross-match level. Younger donors, a young male is considered an ideal donor, so younger over older donor, no major ABO incompatibility. For male recipients, prefer a male donor over nulliparous female over a parous female. Prefer a sibling or a child donor compared to a parent donor. Cytomegalovirus serostatus should be compatible, seronegative into seronegative, seropositive into seropositive donor. And then HLA barrier, if you're doing transplantation for malignant disease, there is some data about which HLA loci match and mismatch status is important. And there is a calculator. We will talk about that. So in terms of haploidentical donor selection, as I said, no DSAs, different ways to define that threshold for DSAs. About 1,000 is defined. This is from EBMT handbook. We institutionally defined it at 2,000. And again, the same factors: young male donor, siblings or offsprings, ABO matched, and first degree relative. And then there is some data about NEMA versus NEPA, like maternal lineage or paternal lineage mismatches. Desensitization approach. So if you don't have any other alternate donor, and all the donors have donor-specific antibodies, then in the context of developing countries, especially Pakistan, so it will become a cost issue. It will be very costly to do desensitization, but this is doable. So you will look at the level of DSAs, and then are they even Q fixing? If the MFI is less than 2,000, that's what we defined. EBMT defines positive at over 1,000, high as over 5,000. These cutoffs are institutional cutoffs. So if it is less than 2,000 and it's not C1Q fixing, then you can proceed with transplantation, don't need to do anything. If it is between 2,000 to 5,000, then we suggest 2 to 4 sessions of plasma exchange, IVIG with tacrolimus and cyclosalsept mycophenolate. If between 5,000 to 10,000, then the same regimen may need more sessions, and then you'll watch the DSA levels, and if they have not improved, then you can consider additional sessions: plasma exchange, IVIG, and tacrolimus mycophenolate. That tacrolimus mycophenolate is continued into transplant and then continued as part of the GVHD prophylaxis. And if they are over 10,000, and then the suggestion is to look for other donors and don't use that donor. This is a calculator. I'm not going to go into details of that. I have this link pasted here. You can Google search haplo donor selector, and it will give you this calculator. And you just need to put in AML, ALL, MDS, that's where it's validated, and it will ask you the age and the CMV status. And then it will ask you about the DR beta 1 and DQ beta 1, that where is the match, mismatch. And based off of that, from all the available haplodonors, it can give you 1 year survival probability. It does not account donor age into question, so recipient age does. I think donor gender also is not accounted for. But other factors it does account. It's not perfect, but it's a usable, I think, useful tool. We usually use it in our practice when we have different haplodonors, and this can give you an idea. I don't think you should solely base your decision off of this, but this is a useful tool. Now, conditioning regimens and graft source. I will go with our institutional, these are from University of Kansas, our own institutional algorithms. Every institution is slightly different in terms of conditioning and graft source types. There are no good prospective studies by the time, and there are some studies, but they are now older. There is registry data, and I'm not going to go into the underlying data about these choices, but we'll just briefly go over which conditioning regimens we've been using. I have shared some of these with colleagues from Pakistan, and they have adopted some of that as well. So in terms of myeloablative conditioning, so myeloablative conditioning is intense regimen. So younger fit person should get myeloablative conditioning. We define usually up to age 60. You should give them myeloablative conditioning after age 60. It's case to case basis. You can use a cutoff of 50 if there are concerns about supportive care. In myeloid disease, busulfan and fludarabine. And fludarabine is given 160 milligram per meter square, and busulfan is given with an AUC of 20 milligram. And we use kinetics, but you can also use the standard dosing. Lymphoid disease, we use flu TBI. TBI is known to be, lymphocytes are very sensitive to the effects of radiation. So it's considered a better agent. It's more disease activity. Uh, but if you do not have access to total body radiation, you can also use a chemo-based regimen. Buflu would be okay to use in that setting. We're not using cytoxan. Cytoxan with busulfan is considered one of the myeloablative regimens, but since you're using post-transplant cyclophosphamide, just to avoid toxicity, busulfan fludarabine is better regimen. There is significant amount of data showing that it's equally effective and probably a little bit more tolerable compared to TBI-based regimen or cytoxan-based regimens. In this ASH, we also reported a meta-analysis comparing busulfan fludarabine with other regimens, and this is our choice, and there is good data to support that. If you're using non-myeloablative conditioning, flu-cy-TBI, that was a standard that was used in the original PTCy studies, fludarabine at 150 milligram per meter square, cytoxan, and then TBI. Single fraction is 2 grays, two fractions are 400 grays. Two fractions are needed where you have concerns about graft rejection, such as aplastic anemia or thalassemia or myelofibrosis, those diseases. If you don't have access to TBI, you can use reduced intensity busulfan fludarabine based regimen. So flu-bu2 instead of flu-bu4 can be used as a non-myeloablative regimen. If you want to achieve more, because the relapse is a big concern, so some people want to do more intensity than flu-cy-TBI, you can do fludarabine melphalan with TBI. That's been used by several. But these are the iterations of the conditioning regimen. And then we give the graft, and graft source, bone marrow is preferred if you're using myeloablative conditioning. And the reason being less chronic graft versus host disease primarily. But if you have access to peripheral blood and that's easier for you, that can be used as well. Data is comparable. GVHD prophylaxis, as we said, cyclophosphamide, 50 milligram per kilo, day 3 and day 4. Celcept is given for 1 month, day 5 to 35. And tacrolimus is started at day 5. It's given IV in the hospital, then changed to oral. The levels are watched. 10 to 15 is the goal usually. Now, there is good data to stop at day 60 and to improve relapse-free survival. And that's our practice. We stop tacrolimus at day 60 if there is no graft versus host disease. in malignant disease. If there is graft versus host disease concerns, then it's usually tapered off after day 100. And aplastic anemia regimen is slightly different. It uses that same flu-cy, and the TBI dose is 4 grays or 2 fractions. And ATG is used at 4.5 milligram per kilo rather than 9. That's the full dose ATG. It's like half dose. And this is because with the lower dose regimen, they saw more graft failure, especially in untreated patients. So untreated aplastic anemia, you need to give more immune suppression, and that's why this regimen was formulated with that experience. The GVHD prophylaxis is the same. So it's cyclophosphamide, Celcept, and tacrolimus. Graft source, there is not good data, but if you're using myeloablative conditioning, bone marrow is preferred. In reduced intensity conditioning, peripheral blood is preferred, faster engraftment, lower risks of graft failure, since it's a reduced intensity conditioning regimen. So most places would want to do peripheral blood transplant. Also, more anti-cancer activity, and that's important in a RIC regimen. We presented this in this ASH. We looked at 550 patients who received Haplo with PTSI, and peripheral blood stem cell grafts have a higher incidence of chronic graft versus host disease, but all other outcomes were essentially the same. So after the graft, you've done the grafting and there is GVHD prophylaxis given. So one of the early concerns is cytokine release syndrome, especially when you're using PTCy-based prophylaxis. You have not given these patients ATG, so they're not lymphodepleted. So now you give them a mismatched graft, so they can have CRS, it's essentially an infusion reaction with that half-matched haplotype. And if it is grade 1, there is no need to do anything else. You still do cover for infections and do supportive care. And grade 1 is fever. Grade 2 is if you have hypoxia or hypotension in addition to fever. Grade 3 is more ICU need, and grade 4 is essentially on ventilation. And if it is grade 2 and higher, then consider tocilizumab. Now we have tocilizumab available since COVID at most places, so that should be considered. There's no need to get that patient into undue complications when they can be prevented by giving early tocilizumab. And this will happen in the days before PTCy usually. So day 1, 2, day 3 and 4, they get post-transplant cytoxin. Even if you don't do anything, this should subside by day 5. After they get the cytoxin, those alloreactive T cells are gone and the reaction will calm down. So you just the first 3 days. And it's dose dependent on the T cell content of the graft, but very easily manageable. I haven't seen any bad cases just because there is early tocilizumab now. Challenges, in terms of challenges, I have been talking about these previously. Relapse remains the biggest challenge. CTN 1101 is slightly older data. It's about 50% relapse rate in malignant disease, AML, ALL, MDS. It's probably close to 30% in the US in the past 5 years or so, but still is the biggest cause is relapse. Then GVHD rates are in 20% range. Graft failure is less than 10%. Delayed immune reconstitution, CMV, infectious complications, and better supportive care and more vigilance is needed. There's no way around it at this point. Relapse, as I said, is leading cause in malignant disease. So you can do maintenance treatment. Some diseases has targeted agents available for maintenance that can be done. Early immunosuppressive therapy withdrawal, as we are stopping tacrolimus at day 60. So patients are off immune suppression after day 60. So that's one strategy. DLI or cell therapy strategies, I think there is margin to conduct trials in this setting. And many of these trials, if you have the Milteni devices, can be conducted in Pakistan and developing country context. And we will hopefully be working on that in future. Second transplant obviously can be done as well. These are the slides showing Hopkins group reported on shortened duration tacrolimus reduces relapse risk. And here you see that overall survival is higher, progression-free survival is higher, relapse rates are lower. All those small numbers, but this is encouraging data supporting stopping immune suppression early. And if you have concerns for GVHD, you can always continue it. But if there is no GVHD, this will make case for stopping it. If you do have relapse, whether there is mixed chimerism, or chimerism is a percentage of the donor cells and the recipient cells, or there is disease is evident on measurable residual disease testing or morphologic relapse, you can give them anti-cancer treatment, get them disease to a lower level state, and then give them donor lymphocyte infusions. And our recommendation is to escalate it just to lower the risk of graft versus host disease. So when you're collecting, you collect 160 million cells, and then you store it in allocards. And the first dose should be 5 into 10 to 5 and increase by half logs. So the next dose should be 1 million, and the next dose should be 5 million. And the max dose should be 10 million, not more than that. And this is all institutional. There are several ways to do it, but doing it in, because the biggest risk with donor lymphocyte infusion is going to be graft versus host disease. So if you do it in escalating fashion, then you mitigate that risk. I'm not going to go into that, but these are some ideas for future cell therapy studies in the developing country context. If we have those devices to filter out like alpha beta T cell depletion, or filter out NK cell or gamma delta cell, they're relatively easy to grow in lab and can be used as post-transplant cellular therapy to prevent relapse. These slides just show NK cells infusions post-transplant improve outcomes. There is currently a trial open at MD Anderson looking at that. This shows gamma delta T cell, an important part of an innate immune system, good recovery of gamma delta T cells, and in post-transplant infusions will prevent relapse and will improve outcomes. There are several phase 1 studies, including we have one here at University of Kansas. If you are to do a second transplant, better to check for HLA loss that is used as cancer as an escape mechanism, and or use a different donor. If you don't have capacity to check for HLA loss, use a different haplodonor. Few words, we are running short on time, so I added these things just to give a context about the challenges that we will face with transplantation. Each of these would require separate talks. This is just a highlight. So graft versus host disease, about 20 to 30% chance of happening after haplotransplant. Treated initially with steroids. So 1 milligram per kilo prednisone in chronic, and in acute is up to 2 milligram per kilo per day of prednisone. And you assess response, and if you don't respond to the first line steroid treatment, or if you respond and then you had a flare, you're steroid dependent, or if you're steroid refractory, then you'll need to add steroid sparing agents, so alternate immune suppressants. And some of the older drugs are cyclosporin and mycophenolate, sirolimus, tacrolimus, but now we have 3 good agents recently approved. Some of that is available in Pakistan. For example, ruxolitinib or Jakafi is available, that is used in acute graft versus host disease. Blemucidal or Rezurock is also used. Photopheresis can be used. There are several other things, but none of those have good data to support it. These beyond second or third line, the outcomes are really poor, and you are going to have 4 or 5% patients like that. Chronic graft versus host disease, with the PTCy based prophylaxis, the rates of chronic graft versus host disease are in 20% range compared to 50% I was seen with older prophylaxis regimens. So that's good. But if you do develop it, and if you're steroid dependent or refractory, then again, Jakafi, Rezurock, axatilimab is a newer drug. It works on the monocytes, macrophages, CSF1R receptor inhibitor. Ibrutinib, Rituxan, they work on the B cell. So if the underlying mechanism is thought to be antibody mediated, then these can be considered. Low dose IL-2 is immunomodulatory, that can always be considered. Immune dysfunction in transplant affects all subsets of the immune system, not just the number of like neutrophils, for example. So there is a profound immune dysfunction that takes up to 2 years to recover. The first generation of T cells that come on are very alloreactive and are donor region. The second generation of immune cells matures within the recipient. So the development happens within thymic area of the recipient, and they are immune tolerant, they don't cause GVHD, and they have their full repertoire. And a simple way to say is that you may see soldiers, like you may see cells recovering, but that doesn't mean that they have an intact immune system. They essentially don't have a command center. So it takes time to establish that. And the 6 months to 2 years is age dependent and depends on a lot of other factors. But up to a year, these patients need to be watched very closely. Infection is a major complication in the developing world, especially in Pakistan, Jordan, other developing countries. And each area will have their own unique set of challenges. The local microbiome and the antibiotic resistance and the drug availability will vary. So the guidelines will need to be tailored to local approaches. But the phase 1 is pre-engraftment. When they don't have a mucosal barrier, they're severely neutropenic. And the risk is respiratory viral infections, bacterial infections, sepsis, gram-negative sepsis. So the antibiotic coverage and prophylaxis needs to be tailored to that. And the second phase is up to day 100, where they do have neutrophils and the mucosal barrier is now intact, but they still are risk for fungal infections and other atypical life-threatening infections, TB, viral reactivations. And then late phase goes beyond 100 days to up to 6 months to 2 years. And it depends on various factors, conditioning and the prior treatments and the age. And viral reactivation, especially cytomegalovirus, remains a bigger challenge in developing world. Encapsulated organisms and zoster and other viruses continue to be a problem. PTLD with EBV reactivation is more of a concern with ATG-based or intense immunosuppressive regimens, not so much with cyclophosphamide. PTCy, BK virus, some other viral reactivations are seen with PTCy, but it is less compared to when you use ATG-based CD34 selected platform. Infectious complications are much more prevalent and higher in those. And I'm not going to go into details because we are going to have dedicated talks looking at these individual issues. This is from a paper published by Dr. Khan and group in JCO Global Oncology. And it's now a little outdated data. 2018 is now 7 years old. But they look at the transplantation indications in Pakistan. They report on 1,600 procedures, and it's still non-malignant disease, thalassemia, aplastic anemia are major indications. Very few acute leukemia patients, and then there are some autologous transplants. They report on haplotransplants. There are a little less than 100 transplants that they had done, and main indications have been aplastic anemia, thalassemia, severe common variable immune deficiency, and then some malignant disease as well. If you are resource limited, it makes sense to prioritize non-malignant disease. The survival is over 90%, as I have showed with haplotransplantation. Even with infectious complication and graft versus host disease and other issues, it still is going to be close to 80%. In malignant disease, that maybe 30 to 40%. So there is a margin of expansion here. I think haploidentical donors are readily available. There is no cost associated. It's just a matter of capacity building and upscaling the existing infrastructure that we have. But there is need and there is margin to expand on that. Access to transplantation depends on several factors like donor types and availability and economics of the country and the healthcare systems, uh, healthcare providers, the social challenges of financial constraints to the family, patient demographics, and increasing access to transplant takes a village. It takes everyone's efforts in there. So establishing minimum requirements for a transplant center, telehealth use. These days we have wearable devices that can be used for remote monitoring and acting on that. Thinking out of box is important. AI use, research agenda that focuses on solving local problems and not just producing science just for the sake of publications, but actually solving local problems, and collaboration with international organizations that can get the needed resources to local communities. And in those lines, we have established Mikael Rayaan Foundation, a global transplant and cell therapy consortium. The aim is to support and advance cell therapy and hematopoietic cell transplant programs in developing countries. A focus has been to focus on Muslim countries initially, because there is much work is needed and very few people work in this area. There have been people working in Nepal, in India, in Latin American countries. Very few people are working in Middle East or Muslim countries, and there is a big need. uh, I personally went through a tragedy 2 years back. We had two beautiful boys, Mikael and Rayaan, who passed away in an accident, and we founded this non-profit Mikael Rayaan Foundation. And we've been doing global health work and working in several other domains, including orphan cares and meals and child health support. And since I have expertise in transplantation and there were several other people interested in doing this work, so we thought that this would be most useful if we get together and provide a platform, and this will have potential to hopefully improve thousands of blood cancer patients' lives in coming years. So I'm personally very committed to that. You can visit the website, and we have some of the updates available. We are short in time, so I will briefly go over some of the future things. I think we should look at GVHD infections. We have infectious ID faculty, so who will be talking about some of those things and how to tailor it to local resources. All of these drugs are available locally in Pakistan. What I talked about mostly, it's more about setting up the program, setting up monitoring and evaluation parameters, and then training. Organ toxicity, we should talk about chimerism, graft function, we should talk about immunizations, emergencies, gynae part. Some of those things we should talk about individually in future lectures. Uh, Again, on that consortium part, so we have established a visitor training program. The deadline for the application for first session was March 31st. So hopefully within a week, we will notify. We are going to have 4 people who will come up to University of Kansas, 2 from Pakistan and 2 from Jordan. And these are our partner institute. And we'll do a training program that will cover fundamentals of transplant and cell therapy. And more details are available on the website as well. We will have more of the lecture series that are focused on the practice of transplantation. And in consortium, we meet now monthly, every Thursday, and more things are coming out of that. We have our global health program at Division of Heme Malignancies and Cell Therapeutics have been very supportive. We have nurses and pharmacists and lab technicians and the faculty who are part of the consortium. So not just training the doctors, but training the lab technicians and nursing protocols, because they are equally important. It is going to need a team approach to improve all parts of the transplant program to have better outcomes, not just the physician part of it, but also the nursing and allied healthcare part of it. And we're hopeful that we'll have a training program for nurses and lab technicians in coming years. And thankful to everybody, all of my colleagues, Dr. Anwar, Dr. Sazwani, Dr. Mehdi Hamdani, our division director, Dr. McGurk, and everyone at Mikael Rayaan Foundation and University of Kansas for their commitment and all the work they do every day. That makes a real difference in the lives of people. And that's why we do all of that. May Allah keep our intentions pure. And thank you so much, everyone, for your attention. And I will be happy to answer any questions at my email or at my cell number. Yeah, always available.
Well, thank you, Dr. Umair. This was a fantastic lecture, and I personally learned a lot of things from this lecture. I'm sure the other colleagues also learned. Not sure if you can take few questions. If you can look at some of the chat questions. Of course, some people are finding information that how they can collaborate with you and to the foundation, how they can be part of the team. There were some questions about the timing of the post-transplant cyclophosphamide. We know typically it's considered day 3 and day 4. And there's a comment that usually it's given around 60 to 72 hours. And then one question was about the minimum dose of and a maximum dose of CD34 cells, as well as oral versus IV tacrolimus. So if you want to address some of these quickly, that'll be great.
I will. So there is first question here is, so after how many hours PT size should be started? So day 0 is you have the infusion. So day 3, so after 72 hours would be okay to start day 3 and day 4. And even like after 48 hours should be okay, but that's why it's day 3 and 4 that it would always be over 72 hours. So, and we should always do it the way it was studied, because in the original studies, they did it several different ways and several different doses. And this was the one that had the best effect. And it is very dose dependent and very time dependent. There are studies looking at lower dose also in matched sibling donor settings. So no, 100% doesn't have to be followed, but we should make every attempt to follow it the way it is. Tacrolimus is given IV when patients are in the hospital, just because the oral intake is not good with the conditioning. So it started as IV, the levels are monitored, and once they are ready to leave the hospital, once they're eating, at that time point, depending on the level, it's changed into oral on discharge. But the inpatient part should be IV. And then there was this question about plasma exchange. So the standard plex for desensitization, you can just follow your institutional practice. Albumin may not make a big difference. So it just depends on how your blood bank or transfusion medicine wants to do it. More plasma exchange, it just you're removing those antibodies. So Rituxan, IVIG, plasma exchange, tacrolimus, CellCept, all of those things happen. The way we have our algorithm, I can share it. If you wanted to follow that, I can make that available. And then minimum and maximum dose for CD34 for haplotransplant. There initially was a concern that over 5 million cells per kilo may have more toxicity, but that didn't pan out. We reported in this ASH on the most recent data. And the higher the number of stem cell dose, the better were the outcomes. You cannot control it in the bone marrow graft. So you'll get a weight-based graft and you'll give it. But if you're doing a peripheral blood graft, then it's more so about the T cell dose in it that may have some CRS concerns. But I would give whatever you have. I wouldn't save it. So if you have 10 million, I'll give 10 million. The minimum dose, I think, should be 4 million. That is the optimal dose, 4 to 6 million stem cells per kilo. Less than 2 million will have issues with engraftment. But that doesn't mean the successful engraftment will not happen. There may be delayed engraftment and you may have to get a boost. But if you are in a situation where the donor have already had conditioning and you get a graft and it is 1.9 million, and you shouldn't delay the transplant course. You should give it and stay the course and prepare for a CD34 selected boost if the counts don't recover by day 35, for example. And for the foundation, it's Mikael Rayaan Foundation.org. You can Google search it also. We are present on social media as well, so you can stay connected there. Social medias are usually updated more routinely than the website. Website is like every 6 months or so. So for donations, like from the US, there is this Zephy platform that can be used. It's in website as well. We haven't had a mechanism from Pakistan yet, or other countries for donations. It's being registered in Pakistan. So once that's done, then I can share that link.
Well, I think we are now past about 5 or 6 minutes past the hour. This was a fantastic session. At one point, we had more than 80 participants, and it's an ongoing series. This is our effort to learn from each other and disseminate the information so we can impact patients' lives. So thank you so much. We will record the session and make it available as well.
Thank you.
Thank you.